Good morning, everyone. Happy Saturday. Welcome to our first town hall in the Beyond the Price Tag series. This series, the heart behind it really is to um, talk about the costs of transformative therapy very transparently and openly. There is a big financial price tag that most people see on the outset. You have $2 million, $3 million for gene therapy, stem cell transplant. Mine was like, half a million. And so you see that big price tag, but there are other things that you also have to consider when it comes to making a decision about transformative therapy. There are other costs that are in the balance. And so this town hall is specifically going to be about fertility preservation during the town hall, during transformative therapy and family building after transformative therapy. So welcome, welcome, welcome. Thank you, Abby, for closing the poll. We have a few folks who are joining us from social media. Oh no, I just realized my poll didn't have, let's see, can I see what's written here? I can't see it. That's right. Okay, California, Delaware, UK. Okay, Rancho Cucamonga, surprise. We've got a lot of Californians here. So it's a good mix of folks. Thank you for answering our poll, and I can't wait to get us started. So today, what you can expect from us is going to be two sets of panels. There will be providers that are sharing their expertise on fertility preservation and family building. We have experts in the field of urology for our male warriors, and we also have reproductive endocrinologist, OB-GYN for our female warriors. And so this is going to be great. And then afterwards, we have our patient panelists who will be able to share real firsthand experience about what that journey is like. It's easy to read a piece of paper or a pamphlet and sort of understand what's happening, but then being in it is sometimes a completely different journey. So thank you so much. Be sure to ask your questions in the Q&A box. And let's go ahead and get started. Here are my lovely panelists. They're all here at the same time, but we will be starting off directly with our female fertility risk and risk preservation process. And we have our lovely Dr. Kamaria Katen-Vaught to give us a presentation. She's a reproductive endocrinologist and infertility specialist at Johns Hopkins School of Medicine, and she cares for women with fertility challenges and hormone-related reproductive conditions. Her research focuses on genetic causes of fertility problems, fertility preservation for people with sickle cell disease, which is amazing, and recurrent pregnancy loss. So she studies how certain genes affect ovarian cells, uses tools like CRISPR to better understand how these cells respond to hormones. So thank you. Without further ado, I will just let you take the floor and everyone else can hide away off camera. Thanks.
Thank you, Christelle, for the lovely introduction. And I am very honored to speak about a topic that come upon almost daily in my practice to help kind of spread awareness about some fertility preservation considerations. So let me just make sure I can get my screen to share. Let me start at the beginning. Can everyone see my presentation, Christelle? Can you see it?
I can see it and I can hear you. We're all set.
Okay, great. Thank you. So I'm going to talk as quickly as I can. I have like 50 slides to go over in 15 minutes, but I wanted to talk today about female fertility and transformative therapies for sickle cell disease. And the first thing I wanted to do is just kind of break down my presentation to what I'm going to be reviewing. So the first part, just kind of understanding your fertility in general. Then I'll talk about the curative therapies and how they may affect your fertility. And then talk about different fertility preservation options for individuals who are undergoing those type of treatments. Before the process, during and after. and also talking about family building options after I've gone through transformative therapy, and then just some information about support. All right, so bear with me. I'm really going to try to get through this first part in 2 minutes. So let's talk about fertility. And for women or individuals with ovaries, as you can see depicted here, you have a uterus, two fallopian tubes, and two ovaries. And the most important thing about implied about your future fertility is your ovarian reserve, or how many ovarian or eggs that you have left. So here's a very close view of the ovary, and you can see here every month the ovary, its main job is to ovulate an egg, and this structure here is a follicle, and the little white structure is the egg. You can see here it's being released out at ovulation. This is kind of overview of a phase of how your ovarian cycle is timed with your menstrual cycle. So as your follicle is growing and developing, your menstrual lining and pattern is also changing, in the hopes that if a pregnancy happens, it can grow and support in that pregnancy. What's very, very important to understand is that as individuals with ovaries or women, we are born with all of the eggs that we're ever going to have. So you have about 6 million eggs at birth or so, and 6 million before birth and about 1 million eggs at birth. And you have a slow decline in that number even before menstruation or puberty starts. And then by the time you reach menopause, or the average of menopause in the US, you only have less than 1,000 eggs left. So we like to think of our optimal fertile windows as somewhere between our early 20s to our early 30s, and we start to see a drop off or decrease in fertility in the mid to late 30s. And the end of that fertile window in the mid 40s. And this is primarily driven by the number of eggs that you have. So what is your egg supply? What is ovarian reserve? What tests do we typically look for or do when we are determining what someone's egg supply is? So I want you to think about your ovarian reserve, or as kind of like your egg bank. Like, how many eggs does your ovary actually have? Depicted here on the right is a picture of an ovary, and you can see here these little black circles are little follicles, and each of those have eggs in them. So the way that I typically can assess ovarian reserve is by 4 parameters. I like to think of them each as a piece of the puzzle, and overall I can get a big picture of what's going on. The first one is AMH, or anti-Müllerian hormone. Then you have follicle stimulating hormone that's secreted by your brain. AMH is secreted by these small follicles in your ovary. You have estrogen that's produced by your ovaries, and then your actual follicle count. How many eggs do you see on the ultrasound? So important thing to even just right off the bat, women with sickle cell disease, even without ever having undergone any type of treatment like transformative therapies, have a lower egg supply than women without sickle cell disease. So we're already kind of starting off a little bit handicapped in that sense. AMH is a direct measure of like the growing follicles. FSH is, I want you to think of it as how hard your body has to work to mature eggs or to ovulate. And when we see a high FSH, we think the ovaries are needing to work more. There's a more increased work that they have to do. The estrogen, as I mentioned, are produced by those developing follicles, and then the antral follicle count. So typically, I like to see at least 10 follicles on an ultrasound between both ovaries, and that's considered a normal number. Some of this testing is very cycle dependent, except for AMH, which can be done at any time in the menstrual cycle. So one important thing is just to get that off the bat is kind of see where your egg supply is. Next, I want to segue into curative and transformative therapies and why this conversation in the first place matters. So gene therapy and stem cell transplant are expanding, access to them are expanding very, very rapidly, especially gene therapies over the last few years. And many warriors are in that adolescent or young adult phase where they may be offered this type of treatment. But the reality we face is that gene therapy and stem cell transplant can cure sickle cell disease, but both treatments require very high dose of chemotherapy. And this chemotherapy is highly toxic to the ovary and causes damage to the ovaries. And in the end, it will affect fertility. So, in the studies that have looked at this, and what 100% of women in recent studies showed ovarian failure after gene therapy, meaning that their egg supply is almost completely gone. And 80% will have had some type of fertility counseling, but this counseling happens after therapy. So we know that fertility preservation counseling is super important. But in recent studies, we are seeing trends where a lot of individuals have this counseling after they've already had these type of treatments, which is not helpful if you want to consider fertility preservation in general. And in this one study that I looked at, only one person underwent a fertility preservation procedure out of a cohort of 20 individuals. So as you guys can see, those numbers aren't very good for patients either having access to these type of procedures or even being counseled that they should be undergoing this type of treatment. And as I mentioned, the chemotherapy that's needed for these treatments can cause great harm to the ovary. So there are ranges in ovarian damage. It can be from what we call diminished ovarian reserve or DOR, where you have fewer eggs than expected for your age. The ovaries are still working and you may still ovulate regularly or release an egg every cycle, but pregnancy is still possible, but it's more difficult. And then you have the far end of the spectrum of premature ovarian insufficiency or POI, where you do have a loss of ovarian function before age 40. You have irregular acid periods. There's very few or no eggs available, and unassisted pregnancy is unlikely. Some clinical symptoms of DOR includes like the low AMH we talked about, the low egg count, and a normal or slightly elevated FSH or follicle stimulating hormone. For premature ovarian insufficiency, also very low AMH, high FSH, often absent ovulation, and you can have menopausal symptoms. So essentially, hot flashes, brain fog, vaginal dryness. As I mentioned, there is a range of ovarian function, and this kind of just outlines the differences between those things. And it's known that conditioning chemotherapy can accelerate this progression from normal ovarian function to POI, where you're either having irregular or absent periods. And so other things that we think about, like I mentioned earlier, is just what markers of ovarian reserve do we look at before and after curative therapy. And essentially, the take-home point is everything is impacted, where you have very low androgen follicle counts, irregular absent periods, high menopausal range of other hormones like FSH, and your AMH becomes undetectable. So what are some options for young girls and women who are seeking transformative therapies in order to preserve their fertility? I'll go through each of these individually. First, I'm going to talk about embryo cryopreservation and egg cryopreservation or egg freezing. So egg and embryo freezing, we need about 2 weeks time period in order to complete this process. It can be started any time in a woman's menstrual cycle. It involves hormone injections and close ultrasound and blood work monitoring. And it's the fertility preservation approaches with the highest chance of pregnancy. So you're looking at around 26 to 35% chance of a live birth per cycle of treatment. And this future live birth is very dependent on the number of eggs that are retrieved after these type of procedures and or the number of embryos created and the time of what the woman at the time of her undergoing this treatment. Embryo freezing, this requires partner sperm. So if you are unpartnered or don't have available sperm, the option for you would be egg freezing. We can perform pre-implantation genetic testing or PGT-M on embryos, and we cannot do that for eggs. And this is the fertility preservation method that has the highest chance of pregnancy. Egg freezing does not require sperm. You cannot perform any type of genetic testing up front. You have a greater control of what happens to your egg, right? If you're not a couple or make a decision, you have autonomy over what happens to your eggs. There's a lower attrition rate. So 10 eggs usually does not equal 10 embryos if you were to come back and use these eggs. Typically, you're looking at maybe 1 or 2 embryos from that cohort of 10 eggs. And so it has a lower pregnancy rate, and there's limited data on pregnancy and live birth rates in patients who have undergone chemotherapy type regimens. So the timeline, I mentioned earlier, is about 2 weeks. And so when you come to see me, we start this process. And here on the far left, you see an ovary that is prior to the stimulation process. And over a period of 2 weeks, you see an increase in the size and the number of follicles. So it goes from looking like a chocolate chip cookie to a bunch of grapes at the very end. And this is the type of ovary that we like to see right before we go in and retrieve the eggs. This egg retrieval process is a surgical procedure. Typically, we do it in an outpatient setting under IV sedation. So you're asleep, but there's no breathing tube that's needed to put you to sleep. So here's the kind of view that I see. So there's a transvaginal ultrasound and there's a needle attached to that. That needle goes into each follicle, aspirates the eggs, and then collects them off. And we send them to our lab, and they're able to assess what eggs are that we can freeze or fertilize if there's partner sperm available. And these are the type of inseminations that we typically offer our patients. You can do what's called conventional insemination, where it's a sperm and eggs in a petri dish, and you kind of let them go at it. Or ICSI, this is a type of a procedure where you take a single sperm and inject it into a single egg. And this is required if you do freeze eggs, because you can kind of see here the eggs have a little outer shell. That shell becomes hardened and it's impenetrable by sperm after it's been frozen. So if you have frozen eggs, this is the type of insemination that will be used if you decide to come back and use those eggs. Here you can just kind of see the culture and development of an embryo from first fertilization to the stage called a blastocyst, where this is a type of embryo that we would transfer back into the uterus whenever you do decide that you want to come back and start your family. For both of these egg and embryo freezing, they do very well frozen. They can last decades in the freezer, we say. And so whenever you are ready to come back and use those eggs, you can. Some unique considerations for sickle cell disease. So individuals with sickle cell have unique risks that must be considered prior to this type of stimulation. But there are very safe and effective protocols that can minimize these risks and increase chance of success. But this does require a multidisciplinary approach between your reproductive endocrinology and fertility specialist, your hematologist, and your anesthesiologist, who will all kind of work together to make sure that you undergo this safe way. Next is ovarian tissue cryopreservation. So this is a process that we freeze part of the ovary. It was experimental until about 2019, and now it has become a widely accepted form of fertility preservation. And it's the only option for prepubertal girls. So these are before you menstruate, you're not ovulating regularly, right? We can't capture those eggs. So instead, we have to take a piece of the whole ovary and then freeze that in hopes that we could either reimplant that ovarian tissue when you do come back to or decide you want to start your family, or do in vitro maturation where we can mature the eggs and the follicles in a lab setting. There have been probably even more than this, 130 live births since 2017 from this type of procedure. And here's just kind of like an outline of how it is done, or we just take a piece of the ovarian tissue, we freeze it, and then later on, we can either mature the eggs in culture, or we can kind of reimplant them back into the body. And then medical suppression of the ovaries. So this is used with certain medications like Lupron. It is not a substitute for egg or tissue freezing, and there's very limited data regarding its efficacy and use. It may help when you're undergoing your transformative therapies for menstrual suppression and maybe reduce the risk of having premature ovarian insufficiency. But it is not and I don't usually recommend this to my patients unless there's no other options for them. And then lastly, there's third-party reproduction. So this may be available for either our patients who just not have time before they end up with their curative therapies to do any type of egg or embryo freezing, or they're post-transformative and they want to have options. So this includes the use of donor eggs, sperm, or embryos, using a gestational carrier, or adoption. So what are your family building options after treatment? So if you freeze eggs or embryos, we can do either IVF with those gametes or the embryo. You can carry the pregnancy if your uterus is healthy. And like I mentioned earlier, the success rates can be quite high. If you froze ovarian tissue, the tissue can be transplanted back to the pelvis. You can restore both fertility and hormone production, and you can try to conceive on your own or through IVF. If you did not preserve your fertility, egg donation can happen with IVF, where we use a partner's sperm, and you can still carry the pregnancy, or you can decide if you want to use a gestational carrier or adoption or foster care. So after treatment, pregnancy is typically very safe. You have improved pregnancy outcomes, and some women may need hormone replacement therapies. But we work really closely with our high-risk OB or maternal fetal medicine specialists in order that you can have a safe and healthy pregnancy. Fertility counseling is part of your care. I know this has a lot of emotional impact. There are support groups for sickle cell disease warriors, and mental health support is essential. And then lastly, I'll talk about the financial costs and barriers for fertility preservation. So this whole process is super expensive. You're talking $10,000 to $20,000 to do egg freezing or embryo freezing, as well as ovarian tissue cryopreservation. And most states do not have insurance coverage that is mandated for this, which is a shame. An infertility treatment is not a guaranteed health plan benefit. There are no federal laws that require coverage for these infertility treatments, and only 1 in 5 employers will provide these benefits to their employees. And here's just a brief overview of a map that looks at what it is on a state-by-state basis. The state I live in, Maryland, does have fertility preservation coverage laws, and I know California also does. But you can see most of the map of this United States, it is gray. So I think that it's very important that we continue advocacy work in order to make this expanded and a federal mandate in order to offer fertility preservation services for individuals at risk for infertility. And lastly, I wanted to do a little bit of financial resources for patients. There are sickle cell disease fertility preservation grants. This is in conjunction with SCRED and NMVP, which can give individuals $10,000 to help with preserving fertility prior to transplant or gene cell therapy. And then there are a lot of other different organizations that can help with, storage costs of embryos or eggs. You have to think about that over the lifetime of you coming back to use the eggs or not. There are companies with grants for medications for fertility. There are, again, storage grants in order to help decrease the cost of storing gametes like egg and sperm. And then Resolve is a really good resource for these type of treatment grants and scholarships that are available. So some key takeaways: gene therapy and stem cell transplant will affect your fertility, and there's nearly 100% risk of ovarian failure. Fertility preservation before treatment is essential if you want biological children. And egg freezing is safe, and embryo freezing for individuals with sickle cell disease when done with proper precautions. Multiple family building options exist after treatment, and there are no one size fits all options, and that's very tailored to you and your what your desires are. But most importantly, it's important to start the conversation now. So before your treatment, ask for a fertility preservation referral. Meet with someone like me, discuss your options with your transplant and gene therapy team. Explore the financial assistance program and consider mental health support. Questions to ask: how much time do I have before treatment? Which fertility preservation option would be best for me as an individual? What are the costs and coverage, and what are my chances of success? Hopefully I didn't go too much over time. I thank you so much for your time, and I know we'll probably do questions at the end.
Yes, we will do questions at the end. Wow, that was such a thorough presentation. Truly, thank you so much. And it's funny, as we were preparing for this event, I was talking to Dr. Katenva, and it just became so evident that I would learn so much. And so this is the kind of information that makes you feel really equipped because you really address the emotional, the financial, the practical, the scientific. And so I just appreciate you for making that so easy for us to receive and digest. So thank you so much. We will take questions at the end. So right now, I will jump right on into the next presentation. We have two providers from UCSF, which is awesome. We have Dr. Yi Lee and Dr. James Smith. Dr. Yi Lee is a pediatric urologist here at UCSF. He cares for children with problems affecting their urinary and reproductive organs, including the bladder, the kidney, and the genitals. As an adult urologist, we have Dr. James Smith, who is the director of the male reproductive health system at UCSF. And he cares for men also with fertility concerns, low testosterone, erectile dysfunction, and Peyronie's disease. And so both are on the cutting edge when it comes to research in fertility preservation, as well as better understanding male physiology. So I will just let them take it away. Thanks for joining us.
Thanks so much, Christelle. We're so excited to be here as well. Yeet.
Yeah, great. And thanks for that great talk, Dr. Katen Vaught. So you covered a lot of stuff for us already, so we can go a little faster. We're going to talk about men with sickle cell disease and the fertility risk that's faced here. And, 90% of men with sickle cell disease will have some sort of sperm abnormality. And just to touch briefly on the other things related to male health, about 25% have hypogonadism, which is low testosterone. 33% are affected with priapism, and erectile dysfunction is twice as common in this group. We'll focus kind of on the fertility part. And there's a few reasons why sickle cell disease can lead to testicles not working well. So there's initially testicular damage just from poor blood supply, the microinfarctions that happen in the testes. For patients who do require chronic transfusions, can result in iron overload that also causes damage to the testicles. And then treatments like hydroxyurea, we know hurts sperm parameters after starting treatment. And also definitely, as Dr. Katenvaugh mentioned, a stem cell transplant similarly causes severe testicular damage in men with 90% with no sperm production after treatment. So those are all important things to consider. In general, for post-pubertal sickle cell patients, so I think in men, we kind of separate, those who can produce a semen sample and then those who cannot yet. And for those who can produce a semen sample, we do recommend early discussion with your doctor about getting a semen analysis. And then, Dr. Smith's going to talk more about sperm banking, but consider banking if that semen analysis shows poor sperm quality, and then definitely before, treatments such as bone marrow transplant or hydroxyurea treatment.
So when you think about a semen analysis, we broke this down into three different ways of looking at this. For couples who have been actively trying to conceive, typically what our guidelines would say from the American Society of Reproductive Medicine is that you shouldn't even start getting a semen analysis or any testing until the couple has been trying for 6 to 12 months. And a lot of times, particularly in sickle cell, we expect that there's going to be problems. And to wait until a person has been trying for 6 to 12 months can lead to a lot of frustrations for couples. So getting checked early can help you address problems, can understand the risks that are involved. So typically, we at a minimum would recommend getting people tested at the beginning of their fertility journey for sickle cell individuals. And potentially even the third bullet point here is that just to understand your fertility risk way ahead of time and just get things checked out. Time is sometimes not on your side, particularly for women. As you heard earlier, fertility can decline as women age. And so getting this information up front can allow you to get all your ducks in a row early. So we looked at a prospective cohort study of first about 15,000 individuals, where we looked to see whether or not people were actually following through with a mail-in semen analysis. So this is the Fellow Health Lab, and we found that over 90% of people were actually following through with semen testing. And this is much, much higher than typical. Guys just don't want to come in the lab, and they'd much rather do it at home. We're finishing up now a paper looking at over 30,000 men, and it's basically the same finding. It doesn't matter if somebody lives in a rural area, in a city, they come from wealthy or poorer areas. The completion rates are very high. So when we think about sperm banking, you might think, well, this is super easy. Guys are producing semen samples all the time. Maybe this is no big deal. But what happens is that when you say, okay, there's a threat, sickle cell is a potential threat to my fertility. Well, what do you need to do? So that's all these bullet points are kind of the typical way when you're banking sperm, particularly when you're doing it in person, is a doctor is talking about the fertility risk. You're figuring out if a person wants to bank their sperm. There are a number of infectious disease labs that are important to get. And so I've listed them here. The main important part of getting these tests is so that you can use the semen sample with the fertility techniques that you heard about earlier. There's typically a very long consent form, figuring out if insurance covers it, and then actually coordinate the banking process. So when looking at success, what we'd seen prior to some of the work that Dr. Lee and I had done was that there was only about 20 to 30%, 40% of people were actually following through with counseling and banking. We found, though, that with a mail-in approach, it greatly overcame these barriers. And we were seeing with adult patients, and this is a paper that we published just recently, there was about 92% chance from the time that the doctor was ordering the cryopreservation, more than 90% of people were following through.
And then looking, similarly at a pediatric patient. So what about, 13, 14, 15-year-olds, or maybe even younger, who can make a semen sample? It's really stressful and embarrassing, and difficult for them to come into clinic and produce a semen sample for cryopreservation. And so we're working on this study now. This is about to get ready to be published, where we show that the mail-in kit also works really well. We had patients as young as 13 in this group that were able to really complete their semen sperm banking through this mail-in kit process.
So then what happens when you actually bank? One of the things that comes up once someone banks a sample is this enough, doc? And should I bank in more? So the most important thing to look at is the total number of moving sperm. And so a couple of these bullet points just to keep in mind as you're thinking about this. So when a person has the semen sample, only about half of that sample is going to survive the freezing and then later thawing process. Only about 15% of the time can you get pregnant with each try of a technique called intrauterine insemination, or the fancy turkey baster approach. About 50% of the time, a person gets pregnant with transferring an embryo. So when you look at this practically, for somebody who had 100 million sperm to start out with, that might be frozen in 4 different vials. And so those 4 different vials might lead to one intrauterine insemination cycle, so 4 IUI cycles, each with a 15% chance of pregnancy. If you had a very low number, let's say 100,000 sperm, there could be 25,000 in each of these. And while that's a low number, that still could give a person 4 in vitro fertilization chances. But thinking about those 2 strategies is really key. Always banking sperm, more sperm is better. Typically, we would say like 3, but a lot of it kind of comes down to these numbers. So intrauterine insemination is a technique of putting sperm up into a man's partner's uterus. You need at least 5 million moving sperm, so 10 million sperm before the freezing process. Again, there's only about a 15% chance of this working. A typical lab is going to freeze somewhere between 1 and 5 vials. If you're going to go down this path, it's less expensive, it's less intensive, but you need a lot of samples if you're going to take this approach. In vitro fertilization, you're taking some number of eggs, let's say 20 eggs. You only need 20 sperm, 1 sperm to go with each egg for a technique called ICSI. At the end of the day, out of these 20 egg sperm combos, maybe you get like 25% of those. So maybe you get 5 embryos. Each time you put in an embryo, you have roughly a 50-50 chance of getting pregnant. So you might have 4 extra chances for future children or future tries if that didn't work. This is very expensive, as you heard earlier. But in this case, 1 sample may be enough if you're going to go down this particular strategy.
So switching gears now and thinking about, what do we do if we kids don't make sperm yet or aren't able to produce a semen specimen? And this is, I think, a little tougher. Unlike on the female side, where it's already been established that you can freeze ovarian cells and use that clinically. On the male side, it's still experimental. So we do have a program available at UCSF, and there's some other places around the country that offer a completely experimental cryopreservation technology. So this is if you're a young child, young boy, you're about to get, your bone marrow therapy or gene therapy, and then you can come in and we can take a biopsy and freeze some of those sperm precursor cells. And we have ongoing research in the lab right now to try to create sperm from those collected cells. But like I said, this is still has not yet been successful pregnancy that's resulted from this work, but we're very hopeful and working on it on our end. So I think to wrap up, important questions to ask your doctor if you're a male sickle cell warrior and you're thinking about your fertility. You can ask what your fertility status is. Should you go ahead and get a semen analysis now, even if you're not thinking about having children yet, just to understand where you are and potentially be able to sperm bank and protect yourself for the future. And then, if you are thinking about gene therapy or transplant or hydroxyurea, which we didn't list here, talk to your doctor about your infertility risk and what you should do to prepare for that. And then you can also find out, depending where you are, what fertility preservation options are available. And finally, if prepubertal, is there a testicular tissue cryopreservation option available with one of the labs or centers around the country?
Good old mute. Awesome presentation. Wow, this is fantastic. You guys covered so much again in such a short period of time. And uh, I remember chatting with Glory. I feel like fertility preservation and sort of male fertility, male reproductive health in general sometimes feels like a black box and an area that we don't really dig into as much. At least I will speak for myself. It's something I'm pretty ignorant in. And so to be able to hear the journey for an adult and as well for young children and what's on the horizon for them, um, I think it really opens your eyes to yes, there are risks, but also there's also hope. And so I'm so excited for the research that you guys are doing, and I can't wait for everyone to ask their questions. I know there's a good male warrior community online that would totally benefit from this information. So thank you so much, Dr. Smith and Dr. Lee. Um, I'm going to go ahead and switch gears now. We've heard from our providers. And now it's time to hear straight from the patients, hear a firsthand experience. What is this actually like? We have the textbook knowledge, we have the practicals, but how do we really know what this journey is like? And so Glory's already come on to the stage here. He's been on one of our panels before, so if you already know him, it makes sense. And if you don't, I'll go ahead and give him a quick bio. Glory is a sickle cell warrior. He works as a tech consultant, which is very Bay Area. He was born with hemoglobin SS, and now he is more than 1 year post gene therapy. We celebrate that. Let's go. And after his gene therapy, he founded Rare Hope Foundation, which is meant to support and uplift others in the sickle cell community. And he's really passionate about global work and expanding access to disease-modifying therapies and transformative therapies across the globe. And as a fun fact, he recently became an uncle, and he's one of four siblings. And one of his siblings is Becky, his lovely sister, who also served as his caregiver, and she's been on our calls before. But without further ado, Glory, great to have you. I would love to have you just chat about yourself, give us a little intro into your journey, and then I can ask you some questions.
Thank you so much for the introduction, Christelle. So as Christelle has already mentioned, I am a sickle cell warrior. I was born and raised in Nigeria. It's a country that is also really affected by this genetic condition. During my time growing up in Nigeria, really the only sort of standard of care for people with this condition, especially during crisis, was really just IV hydration, maybe some Tylenol. So I didn't really have a lot of hope growing up in that, part of the world for what this condition would be like just for the rest of my life. I came here to the US to study 2015. I graduated 2019 and started work, and then my condition started sort of deteriorating at that point. I had a lot more frequent crisis, and I was spending a lot longer periods of time in the hospital. So I knew I had to do something. That's when I started, really doing that work to research about curative options for people with sickle cell. That's when I stumbled upon the work that UCSF was doing with gene therapy and made that decision to go through with it.
Thanks for giving us a background and also this is geared towards the sickle cell community, but contextualizing what life with sickle cell before transformative therapy is so important to always remember. Because just like transformative therapy has a risks and there's a fertility risk, there's also risks with having a chronic disease that impacts all of your organs. And so thank you for sharing that context and giving us a little bit of a glimpse inside your life with the short time we have. That was awesome. I'm going to dive into some questions that will be more specifically tailored towards your fertility journey throughout the transformative therapy process. And so I'm curious, before talking to your transplant team, you said that you were like, okay, I'm seeking out this option because I'm looking for relief. I need to sort of get a better manage on my disease. Were you aware that going through something like gene therapy or transplant would pose a risk to your fertility?
Yeah, honestly, I don't think I was fully aware of it just going in, with those initial conversations. I understood that, you would undergo chemo as part of the conditioning, but when I think chemo, I think like a lot of people, I'm just thinking of hair loss, nausea, some skin discoloration. So it wasn't really till I received that, informational packet that I read through the risks and complications from those drugs that would be administered that I really like grasped that reality. So
Yeah, that's the more you know. And I feel like it's so real. You start to scratch the surface and then you realize
mhm.
there's actually a really big rabbit hole that you need to go down to understand everything. And so as you are learning about this information, your providers, you're reading the packets, your providers are having these conversations with you. How are you processing those feelings as you learn this information? Like, okay, chemotherapy does pose more than a risk than hair loss. It does pose a risk to my fertility. What was going on in your mind and how did you balance that information?
Yeah, I mean, it was a lot to digest. It's not a small decision to make, and it's not a minor complication, so to speak. So I think I went through that thought process the way I do with all my big decisions, really, like considering my faith, family, and friends. So just having those conversations with family, hearing their perspectives. I do have some friends in the medical field as well, so just getting both that medical insight from someone that has that personal connection with me was also extremely helpful. And then really just sitting with it, considering what it's going to mean for me, how I truly feel about it, and what my options actually are, and just weighing all that before I made the decision. So yeah, I would say just really relying on my sort of community to help me voice out some things that I might not be thinking about myself. But ultimately still having to make that decision myself and because I'm the one that's gonna have to live with those results.
Yeah, the consequences will be yours to live with, and um, that's a great answer. I think two things that I'm pulling from that is like, or maybe three things. One, understanding yourself and what your goals are as a person. Like, okay, I do want to be a dad, but I also want to be healthy. So, like, I think it's good to know where you are. And then the second is giving yourself time to sit with it. And then the third is pulling in people who you trust to help you walk through things that maybe you're not considering. So I think that's a great it's a great toolkit for how to process something as potentially intense as this. Thanks for sharing that. Um, and so now we're walking you through. You're like, okay, I want to do transformative therapy. Okay, I'm understanding these are my risks. These are my risks. I'm gonna still go through with it. Tell us more about your experience, like going through the fertility preservation process. Um, because for me, I didn't know anything about what male fertility preservation looked like. I was like, I don't know. It's like, were there things that surprised you about the process? Like, were there any like financial, logistical, emotional, or cultural barriers, or maybe even facilitators, things that you thought would be harder but are actually easier? Walk us through like you walking through that process yourself.
Yeah, to be honest, even having gone through that process, I'm still baffled at how much I learned from, Dr. Katie Vaught and Dr. Ely and
Right, right.
Dr. Smith's presentations. Like as a sickle cell warrior, you think so much about the pain, and those complications that you don't think, oh, this disease also, even before you're talking about treatment, it also still affects fertility.
Mhm.
So yeah, still learning a lot. Uh, I think the process itself, as like a male warrior, is was pretty straightforward for me. There was, like they mentioned, those long documents to read through about, okay, what are we doing? What are your rights? How can, like, just a lot of legal stuff, things to do in times of death, like who gets your sperm after if you pass away? It's
Wow.
interesting,
Never
interesting
thought about that.
questions. Um, but the process itself was, relatively straightforward. I had a preliminary conversation with the doctor about just how it's going to look like, what the do's and don'ts are before the collection. Then, I went in for the actual sperm banking. Did that, and afterwards had a follow-up about the test results, because this, I didn't really have to do any semen analysis, right? This was I knew I'm going into a sort of treatment, so it's more just come in, let's do the collection, and let's see where we are. So we discussed those test results. You know I'm happy mine were positive, but I also wonder if those tests didn't come back as positive, what would be my options then?
Right.
But yeah, so we had that, conversation afterwards, and that was more or less it. I had my, full preservation process covered by the clinical trial,
Okay.
and my actual collection was also done at UCSF, so it was pretty seamless in that regard. Once any bills come through, I can just refer it to the clinical team to take care of. And yeah, the collection process and all of that was straightforward. But as they went through that presentation, I think one thing I noticed that was lacking was just sort of that counseling aspects of that. Um, just having those conversations about what this means for the future and all that. You talk about logistics. I think I'm still not 100% clear on what this is going to mean once I actually do want to have that. Maybe when I want to have kids now, how do I go through that? Or how am I reaching out to? Am I picking up the phone and calling UCSF hospital? Like, what's that like?
Yeah.
And then, yeah, emotionally, I think there's a lot of considerations there. Um, I feel like there are a lot of stakeholders to this type of process, even though I might be the one going through it. But at the end of the day, I'm not the one carrying that child. I have to consider, my partners in this, like, what are they going to have to go through as part of this process? And I think that's a piece that counseling would really help with.
Mm. Yeah, that's such a good call out. And I'm curious, like, even because you're not like in a position to have kids right now, but can counseling be available like when you're like, okay, I'm ready, I have my family here and I want to get things going. Like, where do we go? Where do we go to start that? And I'm excited for the Q&A session because everyone on the panel is welcome to ask questions too. But I'm curious what our providers will be able to share with us in terms of, how do we navigate moving. A lot of it is like, okay, we navigate the now, but like when you start thinking long term, it's like, oh yeah, okay, so what am I going to do about that? And so thanks for bringing up so many good things to be thinking about. I think you actually already answered a few of my questions because I was going to ask you, what are some questions that feel unanswered to you and that you feel like you don't know, like how to move forward with those things? Did you want to add any more? I feel like you already covered everything really well, but just gonna open that floor up for you just in case there's anything left.
Yeah, I really want to know a lot. I want to know everything about these process. I was just doing my research on my own about ICSI, so seeing them
Mhm.
present on that as well was even more enlightening. I maybe the finance part of me also cares a lot about those costs.
Mm.
There's a distinction I feel between when you make that distinction between like fertility preservation and the actual process for conception, because that wasn't covered as part of my trial, right? So once I get to that stage, those are considerations I have to make. And yeah, just what those options are. And I mean, maybe I even end up deciding to adopt instead of using that. Are there resources available for those people that want to do that as well? Yeah, those are just some questions that have been on my mind lately as we're going through this. Yeah.
We need to start a document, a running list for all of our warriors pre and post transplant because it's good to start thinking about it early, like Dr. Kate Vaught said. And I'm so glad you mentioned that. Okay, I'm going to ask you one last question, then we're going to wrap up. Um, just so that we really give folks a clear picture. Um, and you can end off with this. What what was your process? What was your thought process in terms of why you decided to still go through with transformative therapy despite knowing the risks? And what's like one piece of advice you would leave male warriors or any warrior that's considering transformative therapy with?
That's a great question. So I feel like the honest truth is for people going through sickle cell, like a lot of people with chronic illnesses, there just aren't really that many options available to you. You can live trying to manage symptoms and reducing the possibility of a crisis. But like at the end of the day, the life expectancy is what it is for people with this condition. And as a sickle cell warrior, you're not just thinking about trying to make that better for yourself, but you also want to, you have people you also want to live for, people you want to be there for. And that was my primary driving factor for this. I don't feel like sickle cell has had enough resources poured into it to try to find solutions for this as much as some of these other more well-known conditions. If you wanted to, like, let's talk about hydroxyurea, like that was FDA approved in what, late 60s, but it wasn't even used in sickle cell warriors till late 90s. And uh, like stem cell transplants weren't really done till late 90s as well. And gene therapy just got approved, FDA approved 2023. And these, I mean, even with all these, hydroxyurea is still not widely available for a lot of people that actually suffer from this. It's not as available in parts of Nigeria. Um, Stem cell therapy, there's the risk of graft versus host disease. You need those matching sibling donors or any other sort of matching donors. And with a lot of gene therapy, there's the price tag. You mentioned like $2, $3 million. That's the reality for these already FDA approved treatments. So there's so much to consider when you're trying to look at what options you have available to you. And ultimately, I had these long conversations with my hematologist, my primary care providers, and decided that, hey, I think it's best to do this within a clinical trial environment. This is already a pretty proven procedure itself, and I just want to make sure I'm going with a reputable provider and people that are well versed in this research, and yeah, making sure that the important parts, such as fertility preservation, is being considered as part of that trial. And yeah, that was all the things that I had to think through. And that's how I ultimately made my decision to do gene therapy at UCSF, and making sure everything I needed to be covered was, in fact, included.
Mm, wow, that was an excellent answer. Very, very thorough and really empowering to folks who may not know what the next step should be. I think you gave them some very um, clear things they can be thinking about, and just sharing your heart and what your journey looked like. So wow, I could kiki with you all day, but we gotta keep the agenda going. So thank you so much, Glory. I really appreciate you joining us today, and I feel free to put questions in the chat for the patients as well, because this is not every day you get access. Thank you so much,
Thanks so
Glory.
much, Christelle.
I am going to go ahead and invite Reve to come on and just share a little bit of her story. Oh my gosh. I actually will say this. When I was looking into my own transplant, I don't know if I mentioned this, I'm a sickle cell warrior, 4 years post-transplant, and I was trying to figure out if this is something that I should do. I found Reve's video as one of the first Canadians to receive transplant, and it encouraged me so much. And so just to be able to have you on, I'm like, fangirl moment, very excited. And so I'll give you your formal intro. Reve, oh, I should have practiced your middle name. Oh Lord. Agyepong. That was okay. Brown, she said, it's okay. She's an author, she's a registered nurse, she's a sickle cell advocate, a speaker, and a mom. She actually serves as a pediatric sickle cell disease nurse coordinator, and so she's able to combine her clinical expertise and her lived experience to support families navigating the same condition. And so she was the first adult in Western Canada to undergo a successful stem cell transplant for sickle cell disease. And, her journey fuels her advocacy around fertility, survivorship, and life after transplant. And everything she posts on Instagram is just evidence of that. So thanks for joining us, Hervé. I will let you just take it away. Tell us your story because it really is so powerful.
Hello. Hi, Crystal. Thank you guys so much for having me today. And thank you for the warm welcome and introduction. I'm so excited to be here and share my story with you. You gave me a great intro, so I'm just gonna keep it nice and brief and jump right in. So yeah, my name is Reve Brown. As Crystal mentioned, I'm a registered nurse. I'm also an author and a sickle cell advocate, and most recently a mom. In November 2017, I became the first adult in Western Canada to undergo a stem cell transplant to cure sickle cell disease. But today we're not just talking about stem cell transplant. We're really diving in and talking about fertility, family building, grief and advocacy, and really and truly about what happens when a treatment gives you hope, but it also takes something away. So, a little bit about me. In my past, I was diagnosed with sickle cell disease before the age of 2. And I remember in elementary school coming in from recess with burning chest pain, shortness of breath, dizziness, body aches, and genuinely thinking every other child in my class was feeling the same way. I thought pain was normal. Over the years, I had a very colorful experience with sickle cell disease, and I've experienced everything from crippling pain crises that left me hospitalized for days, a pulmonary embolism scare that had me unable to catch my breath, hydroxyurea treatment, which left me nauseous with blue fingernails, red cell exchanges every 7 weeks that left me exhausted but ultimately changed my life, temporary femoral lines for those red cell exchanges that had me crying as my vessels became so scarred while the surgeon tried to force the prongs in to make sure that I could get my treatment. A vortex port in my chest that made me feel extremely insecure in my own body, and gallstones that left me in debilitating pain for years until my gallbladder was finally removed. Sickle cell retinopathy that led to peripheral vision damage requiring laser eye treatment, and eventually hopelessness and enough dead ends that led me to stem cell transplant. And so the decision. I knew that transplant came with many risks, and infertility was a tough one for me. Having children was something I always desired and hoped my future would hold. So I really had to weigh out my options. This was a tough one. Option one, do I not get a stem cell transplant and keep my fertility? Although that meant that if I didn't get the transplant, my health could continue to deteriorate before I even got the chance to, get ready to start having a family, or my body might not even be strong enough to effectively support a pregnancy. Or option two, get that transplant and hopefully I will be sickle cell free at the end, but I would lose the ability to potentially have my own children and go into early menopause, which puts other aspects of my health at risk. And at the time, there was really no option that felt great. But to help me make this decision, I just asked to meet with the radiation oncology team. Through my transplant team, they connected us, and they reviewed charts with me that were comparing, the doses of total body irradiation that my body would receive versus the age I am. And then based on that data, I was told that I didn't really have to think about early menopause until maybe my 40s. And I was like, oh, you know what? That's not bad. That is pretty reassuring. But reassurance isn't the same as certainty. Even when my doctors were hesitant because my health was so fragile, I decided to move forward with transplant and just say yes to fertility preservation, which in my case was freezing my eggs. Freezing my eggs wasn't simple. Years of being a pincushion left years of being a pincushion made it really hard when it came to the frequent blood work that you have to do while you're going through this process. And of course, the hormonal stimulation felt very risky, and my doctors kept reminding me that it could possibly trigger a pain crisis. And of course, the finances. Fertility preservation comes with such a heavy price tag. And for me in my area, no coverage is offered to sickle cell patients. There were different funds that you can potentially apply for, which I did. And unfortunately, I did not, I wasn't a successful applicant for it. But the frustrating thing is that often these same funds and funding can be available to those who might be going for a stem cell transplant, but for various conditions, or maybe if it was an oncology patient. And so it's definitely a barrier and something that felt very frustrating, trying to navigate that, because it wasn't that I wanted to just, randomly freeze my eggs. It was that I was put in a spot where if I didn't, I could jeopardize my future. So before transplant, I was reassured that my fertility likely wouldn't be affected significantly. And a year after transplant, after extensive testing, I was diagnosed with premature ovarian insufficiency, as Dr. Clayton Vaught kind of outlined for us already. My body was in early menopause. My gynecologist, my fertility doctor, and my transplant physician, they all confirmed this. And I was put on hormone replacement therapy to preserve what fertility I think I had left at that time. I had survived transplant. I was cured of sickle cell disease, but I felt like I lost the version of my future that I had always pictured. You can celebrate survival and you can also grieve what survival costs, and that can all happen at the same time. When I met my husband, I told him on one of our early dates that I just came straight and said, I can't have children naturally. My eggs are frozen. If we want kids, it will have to be IVF. No softening the blow, no hiding, just the straight, honest truth. And to my surprise, he was okay with it. He was very supportive through it all and never made me feel insecure about my fertility. He truly is God sent. When we were ready to expand our family, we began preparing for IVF. And then something unexpected happened. I got a positive pregnancy test. Even in early menopause, it was positive. Even with premature ovarian insufficiency, it was positive. We were completely shocked, but overwhelmingly excited. But unfortunately, that pregnancy didn't progress normally, and we were told we were having a miscarriage at 10 weeks. It was devastating, but it also reassured that, my body was capable of doing something that no one thought was possible in the first place. We decided to move forward with IVF, and once my eggs were fertilized and cleared for transfer, I was monitored closely by the internal fetal medicine team due to my pulmonary embolism and my anticoagulation needs. The weeks leading up to transfer involved lots of injections, medications, and constant appointments. And eventually we made it. It was transfer day, which truly felt surreal. I remember crying that morning, not from fear, but just from disbelief that we had made it this far. And after that embryo transfer, we had to wait 10 days to get blood work to confirm pregnancy. And those 10 days truly felt like an eternity. My blood work confirmed it. Pregnant. The first transfer worked. Pregnancy was not easy. I experienced severe nausea from pretty much start to finish. I was having hip pain, round ligament pain, back pain that all seemed to hit me harder and show up sooner than it did for most people that I spoke to. And towards the end of my pregnancy, I began developing signs and symptoms of preeclampsia, which is a hypertensive disorder of pregnancy that can threaten both mom and then baby as well. But thankfully, baby was unaffected and I had a safe delivery. And last April, my beautiful daughter was born. She is a happy, healthy, and lovely little girl. Her name is Nyamiche Brown. And so Nyamiche means God's gift and tree, which she truly is God's gift. And that is really, she's really proof that there's always possibility. And postpartum, moving on to postpartum, I would say that, there's a little bit of a burden in postpartum, of being the first. It has been hard, and my body, of course, has been through decades of complex medical procedures, and I just have a very complex medical history. I've had knee pain, back pain, complex symptoms that no one quite knows how to interpret. They're not really sure if it's secondary to pregnancy, secondary to sickle cell, secondary to stem cell transplant. It's all a big question mark because when you're at the forefront, there is no roadmap. Being the first is a blessing, but it also is isolating, confusing, and can be frustrating sometimes. Every question becomes research, and every appointment requires a lot of advocacy. And sometimes I don't even feel like the patient. Sometimes I feel like the educator, and I'm having to educate the room. And so, kind of in closing, what I want you guys to remember is that surviving transformative therapy is not the end of the story, it's the beginning of a new one. And survivorship includes so many different things. It's not just that you made it, it's also about fertility, identity, grief, and of course, hope. I would say ensure that you have fertility conversations early and honestly, whether you are a patient that needs to have these conversations with their partner, or if you're a patient that needs to have these conversations with your care provider and just let them know what your wishes are and what the next steps are if things need to be escalated. And of course, if you're a care provider that is counseling your patient about transformative therapies, treat these conversations as essential and not optional. They need to happen, and people need to have all of the details so that they can really make the decision that is right for them. Advocacy isn't always loud. Sometimes it's simply just refusing to leave certain questions unanswered. I would say I'm not just a transplant success story. I'm a patient who fought for options, and I'm honestly a mother because I advocated, and my daughter is truly living proof that there is always hope. Thank you guys so much for your time today. I appreciate you all for listening to my story. If you'd like to hear more about my story, you can visit reveebrown.com. And I also published my first book called My Sickled Cells in 2022. And it's my journey of resilience, hope, and faith. So feel free to check that out if you guys are interested. But thank you so much for your time.
Wow. 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 Thank you for sharing so honestly. And I mean, even from our first conversation, it's like every time you tell your story, I feel like I learn a new little nugget. I get a different insight. And I think truly this is the story that, and I don't even know if I want kids like that, but it was the story that I wanted to hear like 4 years ago or 5 years ago. I was like, I want to know that someone has been through this and it's been successful. And not to say that there aren't, but it's not a story I happen upon regularly. So thank you for sharing with us your journey and giving us awesome hope and encouragement and setting the blueprint, for um, how to advocate for yourself and how to maintain that vision for what you want your life to look like and how to partner with your medical team to do that. So I'm going to invite everyone back on. We have about 15 minutes for our Q&A session, and there are a couple questions that are coming into the chat, and so I want to make sure we can get through everything. Thank you everyone for joining us. I'm going to hop right in because I feel like the Q&A session is where we tend to run out of time, so I want to make sure we can get everyone's questions answered. And I'm just going to go in the order that I received them in the Q&A box. Um, so the first question is, oh, this is interesting. Okay, so what type of chemotherapy is received during gene therapy / stem cell transplant? For instance, personally, I had stage 1 lymphoma and received, I don't know what R-CHOP is back in 2022. Um, I don't know if this is quite something in your wheelhouse. Can anyone chime in on this? If not, I can get back to whoever this is if you send me your email address. And Dr. Walters is on. Oh, great. Thank you.
I can quickly answer for these gene therapies right now. The name of the chemotherapy drug is busulfan, and it's much stronger than the R-CHOP that you would have received for lymphoma, which is a monoclonal antibody Rituxan with Cytoxan, vincristine, prednisone, and adriamycin. So the answer is it almost certainly will cause infertility, unlike the a single cycle or several of the R-CHOP, although that carries risks too. So just to put it in context, it's probably an order of magnitude more intensive than what you receive for lymphoma.
Yeah,
Thanks.
just to add to that, busulfan is often the medication we use in the lab when we're trying to wipe out native germ cells in testicles in our animal models. So we use it specifically to kind of ruin the fertility for these animals when we're studying them.
Thank you both for the very clear answer. I appreciate it. I'm going to mark this as answered. All right, moving on to the next one. And I think each of you touched on this, but this question is, does insurance cover cryopreservation or would it be out of pocket? If the latter, what is the cost? Which we did see is in the thousands, but more
Yeah.
context.
So I guess it depends on what. A cryopreservation rate of gametes in general. So like this would be sperm, egg, or embryos. It depends on where you freeze them. Like for us at Hopkins, it's about $800 to $900 a year to store frozen gametes. And there are a lot of options out there that have lower costs, like big storage facilities like Recipient, things like that that are about half of that cost. And I often encourage my patients who are not planning to come back 5, 10 years from now, right, before they're thinking about using these, to consider those. And then in my experience, because we do have fertility coverage through insurances here in the state of Maryland, they do not cover cryopreservation costs. So they may cover the cost of the actual procedure like IVF or egg freezing, depending on the company. But most of the time they don't cover storage fees.
Christelle, can I share something for warriors who live in California who have
Yeah,
Medi-Cal insurance?
please, please.
Okay. This is I think really helpful. And this is the benefit in terms of fertility preservation services. So there's a branch of the Department of Health called Department of Clinical Health Services or Health Clinical Services. I can never remember. I think it's DHCS, but it actually covers up to 3 rounds of productive material collection and cryopreservation and storage for up to 15 years, with some assistance for lodging, meals, and travel expenses related to those getting those services. So the collection and cryopreservation, but not the in vitro fertilization, and the storage period is limited to 15 years. So this is not true of every Medicaid. This is related to the cell and gene therapy access model that California adopted with 31 other states in the union. So this is just one example of how some Medicaid insurance will cover this service.
Well, that's super helpful.
A great point. Like our Medicaid actually does cover iatrogenic infertility risks, including sickle cell disease. So I've had success from some of my patients accessing that. I've only heard in 2 states, Maryland and California, where the state insurances are covering that type of service. But like I mentioned in my talk, I think it's just something that we really need to be pushing advocacy for on a national level.
Yeah, from the male side, typically the cost of banking is something around $300 to $500 a year. That's common in that price range. That's about what it is at UCSF. There can also be startup costs. I think the all-in cost, if there is no coverage, is something like maybe $1,200, something like that, and then like this ongoing $300 to $500. So it can be expensive. The mail-in approach is a lot less expensive. The cost at the fellow lab is about $140 per year, so it's a lot more affordable to do it that way. But again, the more you plan ahead, the more you can kind of work through some of these details. When these get sprung on you at the very last minute, it's hard to figure out the best option for you.
And the pediatric test this biopsy currently is all out of pocket because it's all experimental, so not covered by any insurance. We do try to bundle the procedure in if you're going to get, for your chemotherapy, if you're going to get line placement or something like that, we will bundle it in so you don't have to pay out of pocket for the surgery, but the banking and the storage will be out of pocket currently.
And can you just quickly explain? It's experimental, but not a clinical trial?
So it's an experimental clinical trial, but as in it's not an FDA approved way to store fertility, so insurance companies won't cover it.
Okay, got it. Thank you for that clarification. Awesome. Gonna run to the next question. Oh, can we have a copy of today's slides? I have permission from each of you to share slides. Yes. Okay, great. That is done deal. All right. Is there a peer connect group I can refer my patients and families to with sickle cell disease, strongly considering gene therapy from Arizona to California or nationally? Let me know how I can make this possible so that warriors can support each other. I don't know if anyone knows of any specific resources like this.
I don't know either, but I mean, we're all happy to help out. So, and for the male side, you'd look for a reproductive urologist for kind of the standard clinical post-pubertal treatment. And there's a reproductive urologist in most major metropolitan areas.
Okay. I'll also take a look into this as well. And if I have any information, I'll post it on our Instagram. It's a great question. Okay, next. I think this question's for you, Reve. Can you elaborate more on the hormone therapy and what it looked like for you?
Okay, so the hormone therapy I was on, I guess, in the interim post-transplant to when I actually decided to have children. Well, I've been on so many different things. I started off with NuvaRing before, and then they graduated me to eventually, I think the sweet spot was an IUD, and with that, I did take I had an estrogen gel I had to apply daily, as well as like a vaginal estrogen insert that I also have to take, I think like 3 times a week. And so that kind of was the combination that I was on. I can't remember the exact doses, but that is what they had told me.
Yeah,
Hopefully that
so
kind of helps. Talk to you about
so I think it's more for the treatment of POI, premature ovarian insufficiency, right? That Reve has. So your body's no longer producing the estrogen levels that you need, so we have to replace that. The replacement is supposed to be only enough of what your body would normally produce. Our goal is never to give you excess or extra estrogen over that. But at the same time, because we're giving you this estrogen, we have to protect your uterus with that progesterone as well. So those are the two main hormones that we use, estrogen and progesterone. And then, like Rebecca mentioned, there are different ways and lots of different formulations for that. And women or individuals who don't want pregnancy or contraception, they can do things like a combined oral contraceptive pill or like the NuvaRing, which is also a combination of progestin and estrogen. But knowing that it's a lot more estrogen than what your body would typically need for replacement. If you don't care about not getting pregnant, because in women with POI, about 5 to 10% will spontaneously ovulate, like what happened with Reve, and there still is a chance of pregnancy. Then I typically do estrogen patches. The IUD is a really, really great way of giving you some protection from the uterus and also as a contraception. But there are lots of different ways you could tackle it.
Oh, thank you. This is helpful for me. I'm taking notes. What to go back to the clinic and talk about. Okay, another question for Ray. When you were pregnant, did you experience any sickle cell pain episodes despite undergoing a transplant?
That's a really good question because that is something that I was terrified about pretty much my entire pregnancy. I feel like every time I got an ache or a pain, I'm like, it's back. Sickle cell's back. It's finished. But I actually didn't have any sickle cell crises pain, but I do find that as I was mentioning that I did get aches and pains that at some point I was a little bit worried, and they've checked me so many different times. They checked my hemoglobin FNS levels, and I still had no sickle cells in my body, but I was having hip pain that to me reminded me and almost mirrored the hip pain that I was having pre-transplant. But I know that, when you have your stem cell transplant, the damage and things that have been done to your body before, they're still there. And so I think that yeah, my body was just going through it a little bit with the extra blood volume as well as the weight gain and everything too.
Awesome. Thank you for sharing that. And while I'm here, I will actually ask the question that you had that, yeah, I realize I don't think the panelists can put them in the Q&A box. Sorry about that. Do any of you know how many adult patients have had successful pregnancies after transformative therapy? And is there a network? Are there other folks Reve can connect to?
I don't know if there is a number out there. I think because we're just now starting to see those women in the later stages of, becoming moms and motherhood, that we're starting to collect more data. Now, I will say I can ask some of my colleagues. I know Dr. Pecker is really heavily in this space as far as pregnancy outcomes in individuals with sickle cell disease in general, but maybe looking more at post-transformative therapies. And I know, like, my husband, he's a high-risk OB, so he's an MFM specialist and he takes care of a lot of these patients as well. But I don't know if we have a whole lot of data yet and these to look at.
Yeah, I would love to develop that kind of system. Measuring outcomes after fertility preservation is something that we just really haven't done too much of, and I think that would be a terrific thing if we built that into this collaborative effort. That would be outstanding.
Definitely an opportunity there. Stay tuned, guys. Okay, next question. Does chemo/total body irradiation also affect your ability to carry a baby to term? Not just the getting pregnant aspect.
Yeah, so we don't think so. Right. So these type of therapies typically don't cause like long-lasting or harmful damage to the uterus and its capacity to carry a pregnancy. Now, there may be sequelae that you had prior to your transformative therapy that may still persist, right? Like individuals with high blood pressure, individuals like with avascular necrosis and have hip replacements, things like that, that may change your trajectory for your pregnancy. But the chemo and the irradiation itself, we do not think. There have been studies not in the sickle cell population, but in like breast cancer, where there's a lot of data looking at women who had chemotherapy and other curative therapies, then the bone marrow transplant, right? And we do not see increased risk of like preterm labor, preterm delivery, or any type of even congenital or genetic birth defects in like ovaries that have been exposed to this, but maybe they were able to conceive without.
That's super helpful. Thank you so much. Okay, next we have 2 minutes left. If you guys are open to stay on for 5 more minutes until 35, I think I can get through a few more questions and then we'll just wrap it up. At 35, we're gonna wrap it up. I think this is a good question though. The UCSF or one of the doctors mentioned hydroxyurea and how that impacts the fertility of males. How does hydroxyurea impact the fertility of females?
Great question of something that I did not include in my slide, because like I said, there would be a lot, a long discussion.
I cut you a little short.
Yeah, so hydroxyurea, and again, this is a lot of work driven by Dr. Pecker, and we're actually looking at a study. We're recruiting patients for this, where we're looking at what their ovarian reserve is and what exposure they've had to hydroxyurea. The short answer is yes, hydroxyurea can impact ovarian reserve, similar to how it can impact the number of sperm available. Now, we don't understand all the mechanisms behind that, but we have shown consistently in women who are exposed to hydroxyurea and also adherent to their therapy, right? People could say they're taking it and not be adherent to it. We have shown that they have a reduction in their ovarian reserve. Or X.
That's good to know. Thank you. Next question. Is there a minimum age for cryopreservation of testicular tissue in prepubescent boys? My child is 3 years old. How much tissue is needed? Does it vary by age or size? Will it cause like a physical deformity? How long has this cryopreservation of testicular tissue been experimental and what are the outcomes? How promising is it so far? And besides UCSF, are there other hospital systems that offer this as well? It's a lot of questions, but great ones.
Do you want to dive into some of that and I could dive into some of those?
Sure. Yeah. So right now there's no minimum age. We offer this for patients either who need bone marrow transplant for sickle cell or who need chemotherapy for cancer. And so I think the youngest we've done is 5 months. In terms of how much tissue we take, there's not a great answer. Our current protocol, we align with some of the international cohorts that are consortiums that are doing this research. We take about 20% of one of the testes. And the reason why we do that is because on one side, we don't want to be in a situation where we've done all this, preserved it, have been storing it, and then find that when we are able to use it, we don't have enough tissue. So that would be not great. But on the other hand, we don't want to cause any, like your question asked, any long-term damage or issues to the testicle. And so far, it seems that taking 20% doesn't cause any, loss of the testes or injury, at least to date. I don't think it really caused a deformity. That testicle could be a bit smaller, in recovery, and then typically will catch up during puberty and development. But maybe there might be a small difference in the future that shouldn't be significant. This research has been going on, Jim, at least 15, 20 years now.
Longer than that. So there are two main ways that are most promising for us to look at how we could use this testicular tissue. One technique is to take that prepubertal testicular tissue and transplant it back to the child. That kind of technique has been done since the mid 1990s, first in mice, and then in a whole bunch of other animal species. And then a couple of years ago, it was done in monkeys and was published with a live birth from monkeys, taking the tissue, transplanting it back, and then having healthy baby monkeys. It's never been done in humans, but we're very close. And that's something that Dr. Lee and I and our collaborators around the country are thinking about. The second way to do it is to actually grow these prepubertal stem cells all the way to sperm. And that's only been done in mice. It's never been done in any other animals yet. So that's something that Dr. Lee and his collaborators in the lab are working on. So we've been working on this problem for many decades, but as in many issue areas, it's underfunded, and it's something we'll continue to work on until we've solved it.
Awesome. Thank you so much. So thorough. There are two more questions. There is one comment I want to mention before many people log off. There is a support group, Project Spirit support group, that has discussed this in the past. And there's Dr. Reverend Lorraine Brown. I actually have her contact information. So if anyone wants it, feel free to reach out to me directly. We have 2 more minutes. Um, there, I think we talked about this question online. Kaiser Insurance stated gene therapy is not available for people who have hemoglobin SC. Is it that gene therapy is not approved for SC, or if Kaiser doesn't cover it? Dr. Walters, did you want to give a quick answer to this?
Yeah, very few SC patients have been treated by gene therapy, gene editing, so the risk and benefit profile hasn't been established, and so that indication is not FDA approved. Now, as a treating physician, I know that some of the SC persons have just as severe disease as SS, so I have advocated for at least one of my SC patients successfully to get one of the treatments approved. So it's not impossible, but you do have an uphill battle to convince the payer that this is a suitable indication. There is interest in conducting clinical trials for some of the as yet unapproved gene editing, gene therapy protocols. So there may be opportunities to participate in a clinical trial if you have SC as well. So keep your eyes open for that.
Okay, great. Okay, last question. We made it, guys. Okay, are there certain conditioning regimens that use less chemo or radiation, and is there a correlation with the likelihood of preserving fertility? Is fertility returning to bone? I'm not really sure what that question says, but you can just answer the first one.
I'm going to pop in just real quick from the male side. So I served on our American Society of Clinical Oncology fertility preservation guidelines just recently. And so in that, we didn't specifically talk about sickle cell, but part of it did. And one of it is basically not to think about the fertility threatening risk before thinking about banking. Essentially, if there's any risk, you should think about banking. So a lot of times it's very unpredictable. And so some people might get a little bit of chemo and have a big problem. Other people might get a bone marrow transplant and still have some sperm. And it's just, we've not been able to come up with good risk calculators to really know that for sure. Sometimes people will start out with a little bit of chemo and then need a whole lot more before too long. So if there's any fertility risk, preserve your fertility.
Yeah, I'll piggyback off on that. So, any risk at all, come see us, talk to us first. But there are some lower induction regimens and lower dose chemo, but I have had patients with this, and you shouldn't think that just because you had lower dosing of these type of agents that you're going to have less harm to your ovaries or your sperm, because I will tell you that, like Dr. Smith said, there is no correlation that we can safely say. Now, we do know that there are certain doses that are definitely associated with high risk of having ovarian failure. But I would say that you cannot go based off of that alone. And then to the answer to the second question, is fertility returning post-bone marrow transplant possible? It is. So it depends on, one is the age of the individual at the time, like as far as women goes, the younger you are, and the higher your egg bank or ovarian reserve is prior to exposure, the more likely that you may have a resumption or return of fertility. But it's very common that this will not appear within the first 12 months to 18 months after you have been exposed to those type of agents. And so we do see, at least in like the breast cancer population and things like that, and other type of exposures, that there are some chances, but you cannot bank on that, and you should get the counseling if you can, preservation prior to exposure.
Wonderful. Okay, we're 2 minutes over my 35 limit. So thank you, thank you, thank you, thank you so much. Just really feel free to send your thanks to our panelists who have gone over time, and we're so intentional about preparing this talk. I really appreciate you sharing all that you know and even your personal stories to give us some real context. This will not be the last. Feel free to reach out to us at UCSF Sickle Cell on Instagram if you have any more questions or want to hear directly from any of the providers here. But without further ado, I will let you enjoy the rest of your Saturday afternoons and evenings. And thank you so much for being here.
Thank you
Bye.
for having me. Bye.